Ladies and gentlemen, thank you for persisting in what has been a fairly long morning. So my name is Jane Halton. I have a number of hats these days, but one of the hats I'm proudest of is being a board member of IHME. We have now an opportunity not only to have a bit of a discussion amongst a number of people who I think you can say reliably will have opinions, but also to give you an opportunity to ask some of these people some questions. So I'm joined on this panel for discussion by, in no particular order, Julio Frenk, who I think is very well known to absolutely everybody, a man with a completely stellar career, which is far too long, and you can read the bio in the booklet, but these days hangs out in Miami, but he also is the chair of the board of IHME. Paul Romer, who is the chief economist at the World Bank, so we're going to be able to hear from an economist directly about some of the things we have just heard from Jim Kim. Peter Piot, a man similarly with a stellar career, and then Kim Longfield, who has had herself an interesting and varied background. So it's with great pleasure, and I should say at the outset, this is not a session where there are going to be a series of presentations to begin with. We've had some very interesting presentations this morning, so this will be an opportunity to exchange some ideas. So let me start by asking the panel, and I'll ask Julio to go first if I might. We heard this morning from Bill Gates a small potted history that showed us the development of the GBD. It showed us the change from an idea of a country estimate right down to the very detailed mapping that we are now able to do. He talked about the implications that have come from this capacity and the change that we are seeing in outcomes in global health. So if that's what we've been able to achieve in the last 20 years of the GBD and the last 10 years of IHME, what can we expect in the next 10 years? Where should we aim? What should we achieve? What can we hope for? And I'm very minded of some of the questions that we've heard from audience members, and particularly that very passionate speech last night about the need for political action. So let me firstly ask Julio, and then I'll go to other members of the panel. Julio.
Thank you, Jane, and thank you also for allowing me to go first, although these are not going to be long presentations, but more of a dynamic conversation. But I apologize ahead of time that I need I'm going to have to leave discreetly before the session is over to catch a plane. So I thank you for allowing me to go first. You know, I thought Bill Gates really did a very, very nice summary of the history. I've been very privileged to have accompanied many, many chapters of that history, starting with a very early presentation of the thinking around the methodology, the approach, the conceptual, and the first empirical work around the creation of the DALYs, the Disability Adjusted Life Year, which was the metric that drove a lot of the work back in 1987 in Puebla. And that coincided with the creation of the National Institute of Public Health in Mexico. And then subsequently through WHO, the years at WHO, and then now at IHME, I've had this privilege. I thought that the areas that Bill Gates mentioned for future directions, working on reducing the error bars, reducing the latency period between the time when the data is generated and when we can actually do the analysis, increasing the geographic resolution as he illustrated. And then he mentioned as a fourth area, one that I think is critical, which is the collaboration, the partnership with countries. I'm proud to say that Mexico was the first country who did a national burden of disease study with a very, very close direction from Chris. So we were early we're in the early betting team that this was actually going to do something important. And Rafael Lozano, who's here, led that work and has continued to be involved in that. But But I think in that dialogue, in that dialectic between the global public goods production of the concepts, the methods, and then its actual application in a national setting, I think that then fed back to further refinement of the concepts and methods to the global public good. And I love when Bill Gates said, you know, these are complementary efforts when he was talking about Ethiopia, of how we align the global efforts and the national. Because just as Jim Kim was talking of this false dichotomy between social and economic policy, I think we've lived too long with this false dichotomy between global and national processes. And I think Mexico, as the first adopter really enriched the methods by an actual application. And this was very early on. This was in 1993. So actually the national exercise even predates the Lancet publication and has continued. Mexico, just by the turn of events, in which, you know, 6 years later, I was appointed as the Minister of Health, happened to be one which explicitly used one of the earliest examples of a country using the GBD framework to drive the health strategy for a country. And it really drove the strategy. It changed the discourse, because by measuring non-fatal health outcomes, brought to the forefront of priority thinking health problems that don't kill, but produce a lot of disability, mental health being a prominent example of that. It shifted the focus on a rigorous way of setting priorities in a middle-income country really torn by huge levels of social inequality, where balancing the claims of different groups was politically complex. It gave a scientifically based, evidence-based approach to priority setting that allowed us to extend insurance to 58 million people, which did not have insurance before this reform. And then, talking about the geographic resolution, it allowed us, because inequality is such a big problem, and it is geographically, geographic distribution tends to have an important influence there, it allows to conduct some of the earliest subnational, state-by-state estimations of burden of disease. So I would say that moving forward, those 4 areas, plus the area of forecasting that Bill also emphasized this morning, will be very important. But I do think that to the extent we engage in these systematic country partnerships, this is where a lot of the action and in that dialectic between the local application feeding into the global production or the production of global public goods that benefit countries around the world. As we see a retrenchment from the values of evidence, from accountability in many countries, as Richard Halton was showing yesterday about people having a democratic retrenchment, introducing these tools will not just be a technocratic exercise, but will be a hugely consequential exercise in moving countries forward in the route of transparency and accountability for results to their people. And that can only help to advance the best causes in the world.
Thank you. And so to Paul, you're sitting here amongst a large number of people who come from a health perspective. You're our tame economist for today.
Okay.
Yeah, not token, I did not say token. Okay. I said tame. So Paul, you've come to this discussion from a particular perspective, and now you have someone in Jim Kim who has a background which is unusual for the head of the World Bank. If you were to prognosticate about the future of the GBD, where would you see it going, and where would it be most useful, do you think?
Well, let me just start by saying that if you were following finance carefully, you know that there were these things called collateralized debt obligations, which took a portfolio of debt and then sold it as a package. Then there were CDO squareds, which were CDOs where it was a portfolio of CDOs. So I think I'm a freak choice squared, because I was a freak choice of a freak choice to become the chief economist of the World Bank. So, and I'll describe in a minute how freakish this is. But the question is, I was trying to think back how Jim and I bonded. And it was over the discussion of the 3x5 initiative and this concept of scale and this sense of possibility. And we discovered that we both had this sense that way more things are possible. And it isn't just what the GBD does organizationally or its direct products, but it's the possibility that it could just change the lives for billions of people. And there's lots of things that could go wrong along the way, but it could really be just profoundly, transformatively important. So you got to be excited about that kind of possibility. To explain how kind of freakish this is, the first question I asked when I got to the bank was like this: should we just get out of the advocacy business entirely and just focus on science at the bank? It's very closely related to the question Richard Halton was posing, but you could tell he was kind of steering it in a different direction. And if you think about the whole thrust of Jim's speech, it's a testament to his tolerance for intellectual inquiry that I survived at the bank even asking that question. But I think it's important to think about this carefully, because science is really the greatest human invention. It's the thing that makes all of these other things possible. And science could be under threat. It's not guaranteed that it's going to survive. I was worried about trying to isolate the science from advocacy and trying to have a division of labor so that the science doesn't get kind of delegitimized. But as I've spent time getting to know Chris and the GBD, I had already come to the reframing that Richard implicitly suggested, which is, I shouldn't be talking about science. I should just be talking about accountants. We can have kind of accountants and advocates. And I think there's something incredibly important about accounting. Now, Jim, of course, persuaded me that the bank needs to do advocacy, but I think it also needs to do accounting. And what the GBD can do for us is help us do it well. There's all kinds of stories about how measurement in isolation can have huge benefits. Like the maps of the cholera outbreak in London in the 1854 outbreak. But what those kind of isolated measurements can do is lead you with this long list of things where you say, oh, we should do something about this, and we should do something about this, and we should do something about this, and something like this, and something about this. On this WDR in education that Jim referred to, when I got to the bank, one of the first things I told the authors was that I will not clear this report if the frequency of the word "and" exceeds 2.6%. Because it turns out in bank writing, the "and" had gotten up to the point of like 5 to 7%, because we said things like, well, you should do this, and this, and this, and this. And if you think about what Bill was saying about we use the GBD to prioritize, the problem with all those ands is that we're not thinking about priorities. And the reason we're not thinking about priorities is we don't have an accounting system where you can actually compare and decide where do we go first. And this is a subtle thing, because it's not just like what's the product, like the value right now on this one relative to that one. You got to have a dynamic vision. It's part of what Bill was talking about the forecasting the dynamics of disease. You got to think about a decision I make right now is going to have effects now. It's going to have them in the future. Where's the place where I'm going to get the biggest payoff? So I think what Jim was proposing and what we can learn from Chris and do is take the work they've done about bringing accounting to health and then extend that to the other critical dimensions of investment in human capital, be fully cognizant of what this means both at a point in time and over time. And so I'm ready to wrap myself in the mantle of accountancy now instead of science, and say we really need to do the accounting right. And the accountants need to be in conversation with the advocates and vice versa. But it is clear for the credibility of the numbers that the accountants invest in this kind of notion of objectivity and reliability.
Thank you. Kim, so where is the future? Where are we going? Where should we go? Where can we go?
Okay, well, I think for most of my career, I've worked with implementers. And so taking it down a couple of notches in terms of the utility of the DALI, the Global Burden of Disease for Informed Decision-Making on the ground. It's really helpful because it's a unifying metric if you're working in health, and that's unusual. And it helped, I worked for PSI for 15 years. They embraced the DALI back in 2007, and just like Julio and Paul were saying, it really helped with prioritization. Really understanding, at least at a country level, where you should be working and where you have the most potential impact. What I don't see happening is that sort of decision-making trickling up to what we've just said, investments and funding. And it would be really nice for bilaterals and multilaterals to use the information from GBD to inform more decisions about where the best investments can be made and help people prioritize. At an implementer's level, they're really beholden to what their donors pay them to do. And they're often constrained by a set of commitments that they make at the beginning of a contract, maybe a 5-year contract. It isn't every donor that's very tolerant of change. The Gates Foundation and some philanthropists are, but not most. And so that, I think, would really be useful. And like Paul, this idea of bringing the science with the advocacy, and what is the sweet spot there? Who does that? Who advocates for that? I'm not sure. I'm not sure because there's an elegance in terms of persuasion and appealing to people's hearts and minds, including donors and constituents. So I don't know if scientists are the best to do that. I don't see them doing that well. I don't necessarily do that well. But others can bring those messages forward in a good way. I'm not sure who the right body is, but it seems like better support is needed there to simplify messages and make sure that they resonate with the right audiences and the people in a position to affect change. I thought the Goalkeepers report that the Gates Foundation just did, which was fed with IHME data, was brilliant. And it must have been incredibly hard. And I think it took them a few months to do it because just to boil down so many data points into the most simple messages is very hard. And that's what policymakers and funders need. You know, they even said when they delivered the message through video, if I had to pick just one statistic, if I had to tell you why family planning is important, if I had to make just one investment, and I think that's what people need to hear. Otherwise, it's overwhelming. So prioritization and funding.
Okay, thank you.
Thanks, Jim.
And Peter?
Same question?
The future.
Yeah, the future.
The future.
Yeah, I'm here because I'm, I guess, the chair of the Independent Advisory Committee, and all our discussions are really about the future. But before going into that, just an anecdote how I got involved into this extraordinary journey. It went back when I was in the UN. I was head of UNAIDS, and we had a group called the H8, and where any multilateral plus the Gates Foundation active in health were represented, including World Bank, WHO, and so on. And we spent a few hours complaining about Chris Murray and you know, and IHME and the GBD and etc., and how bad the methodology was, and so on and so on. Although nobody, I think I was the only one actually who could understand more or less the methodology. And I said, let's stop complaining and do something. And then I was delegated to, you know, to be the representative of this whole body of institutions that use the "and" word, far too much, and became an observer at the IHME board. And I was a skeptic. I mean, it was not love at first sight, but I was also desperate for data, for estimates, for accountability, and so on. And I think it's probably typical how this GBD community, because that's what it is. Yesterday I was thinking there is a GBD community that is growing, and that is a global community. That's how it was growing. But there's still lots of skeptics there, including in my own institution, the London School of Hygiene and Tropical Medicine. Now, and I think nobody used that word, but GBD has been a game changer, not only in global health, but in health in general, and I think also for international development. Now, for me, just 3 points. And the first one is less under control, or actually not at all under control of IHME and the GBD enterprise, and that is we need better data. There's no doubt about that. And I've been hearing that for years, every World Health Assembly and so on, you know. And yet there's not been really serious investment in more robust primary data. And then it's the same people who don't invest in it, they may criticize that, you know, you make estimates in the absence of solid data. And I've become quite a skeptic, and I wonder whether it's even possible to have such strong data. My father was an economist, and one day, being very frustrated with our kinds of estimates, this was on HIV, I asked him, how on earth do you put together the the GDP estimates? And if it goes up by 1% instead of 1.5, that can break careers. And the accuracy of these measurements is as good as, well, anything as my knowledge of astronomy. And so I think that better data, and that's, I think, a discussion we have to put on the table also. Kim mentioned the Ebola epidemic, and I think just as AIDS created global health, was a game changer for that, I think Ebola has created global health security and an awareness that we need to be prepared for that. We need that discussion. But I also think that we need to see beyond classic collection of data, so-called epidemiological surveillance, which is the dogma and is suffocating, in a way, public health. We need to think where the data are, where we don't have to collect them actively, but just have to capture them. With the Internet of Things, the data that are out there and that we are not accessing at the moment, just it's phenomenal. Also, I think that the time has come, and pending also privacy concerns and so on, which are real, and I think in Europe we're much stronger on that than here, is that, you know, all the health service data and so on that could be used. So I think that's one thing that for the future. And being the GBD is not only about estimates of what's there, but also has revealed what we do not know. Secondly, I think scenarios. This is really exciting, and I agree when I read, 4 pages in The Economist on health estimates. That is worth more, excuse me, Richard, than 400 pages in The Lancet.
That's true.
And it was all based on GBD data, the goalkeepers report. And I felt really proud that that's, I think that's an achievement, and we need to think about that. How can that be done better and so on? I'll come back to that. But refining the scenarios, because the GBD, what people die from, that represents the past. What people are sick from, that represents the past. For a policymaker, for resource allocation, for prioritization, it's about the future. And we're only at the beginning, I think, of these scenarios. And we need to connect them beyond the health field. At the moment, they're quite concentrated on, 3 scenarios for a specific health issue. But they're so much influenced by all kinds of things that are going on in the world. And so going beyond health even more, I think, is really going to be critical. And also daring to do some, like, what-if type of exercises, which I think in the global health community, including with activists, is not something that we are allowed to do. And the hypothesis of a decline in funding is something that is a taboo, but we have to face it. And then, we have to face the consequences. And thirdly, I think, I would call it kits for policymakers, for decision makers. The goalkeepers is one. I mean, that's what's going on and what may go on in the future. And then secondly, tools for accountability. And that's then accountability, that's the democratization in a sense of health. We have an app now that it was just launched, I saw yesterday, I haven't checked it yet. But this accountability where people are at the center of health and development, that's also what the GBD can provide, I think.
Thank you. Well, I downloaded my app yesterday.
Would you mind just a tiny bit of exchange?
I mean, please go.
There's a very important point here about better data. From the scientific community, that usually means something like smaller standard errors or more control over causality. When you start to think about it from the accounting perspective, you realize the importance of something that Bill mentioned several times, which is latency.
Yeah.
Because latency might be much more important for a kind of trial and error learning. Like in Peru, they were able to get stunning down very significantly over about 10 years, partly because they actually did the household survey every year.
Yeah.
So you could see, okay, we've got conditional cash transfers, raises the demand for going to the doctors. Nothing happened. Oh, okay, you got more demand for doctor visits, but no more supply of doctor time. All right, that's not gonna work. So then you kind of increase the supply. Then you have a publicity campaign as well. In the end, you get stunning down. You don't know what caused it, but the latency helped you do it, and you don't need to know what caused it, because the next country you go to is have some good accounting, try a bunch of things, you'll get stunning down. And no, we don't know which one will work perfectly, but we got some good candidates to go try. So it's a slight shift, I think, from just the what would produce a good paper perspective to what's the kind of data that will really get progress going.
So, even if I'm an academic now, I just agree with you. And also, I think with social media have introduced big data in social science.
Yeah.
And that's, I think, the connection we have to dare and confronting the, the classic epidemiology community and so on, and say, look, get real, and while we try to have the causality and all that in there, we need to have tools that are practical.
So, I mean, accountants are the one group that economists can look down on. You know, they're even more boring than we are, and everybody hates the accountants, but I'm aspiring to be an accountant now.
Actually, I think they all look down on actuaries, but anyway. So one of the things that we know is that if you keep doing the same thing, you can't expect to get a different outcome. You know, you're going to get the same outcome.
Yeah.
So those of us who've been around global health for a long time, there's a certain sense of sameness very often. And we struggle with how we get decisions made, to get people to put priorities on things. And when it comes to decision making in a political and a service delivery context, very often there are multiple variables that will influence what you will actually do on the ground. So Paul, if I can start with you. So Jim, in his speech today, talked about something which is quite a different approach. And for those of us who would like to see some change, how important do you think this is, recognising that what he's proposing is quite controversial and will be very difficult, and I think politically will cause one attention and possibly not in a good way? Yeah. So what is your take on that?
One thing I've learned is that when I tell somebody something they don't want to hear, and they tell me I didn't say it in the right way, I tell them, you know, there's no way to say it in the right way when you don't want to hear it. So you just got to be ready for people that tell you you didn't say it the right way and they're unhappy with you. But you persist. Like when the United States started tweeting or just putting on their webpage the PM 2.5 levels in Beijing, you know, the Chinese government treated it as an act of war. And I think we did it in China because, you know, we were happy to offend them and we wouldn't do it to our friends. But this really changed the political dynamic of the discussion about air pollution. Last time I was in China, there were these big banners outside of stores about, you know, like the air filtration system and PM 2.5. So I think the provision of information can be profoundly influential, especially if it's credible and objective. I think we just full steam ahead, we do it. Some people will be unhappy, that's okay. Nobody likes the accountants, but we can change the world.
And as our tame economist for the day, what is your expectation about change behaviours in the markets, and particularly amongst senior leadership? I mean, if we think about it, what is being proposed here is something that goes to the very core of how you govern effectively. What's your prediction about success?
I kind of warned you in the beginning, I'm a huge optimist about what's possible.
We like optimists.
And again, you think about the story in China, that the accounting and the numbers can both change our understanding of the technical solutions, but also they can change the political economy. So I think this kind of information about how important human capital is and all the different things that we do to invest in human capital can really change ideas. And ideas was it your phrase about ideas and power that?
Never underestimate the power of ideas to change the ideas of power, the ideas of those who are in power.
Yeah, exactly. I think that what we can do is use the accounting to change ideas, and those ideas are, I think, much more influential than we realize, and really important good can come of this. And let me just tell you where this is going to go. One thing is we've got to measure whether students are actually learning in the classroom. You know, if we do that and then we start trying hard, we can help make sure they learn more. We got to be sure that everybody's healthy. They're not stunted, they're well nourished, they don't have a big disease burden.
And they can hear in a classroom.
But there's another dimension which we're not paying enough attention to, which was behind those things that Jim showed you about the value of human capital. People learn on the job as well as in school, and we're not measuring this at all. And it means that we don't worry enough, we don't pay enough attention when somebody's disconnected, excluded from the labor market around the world.
And so to the extent that economists spend a lot of time worrying about improving productivity, you would see this feeding into that discussion as well.
I actually hope this displaces productivity and we realize
excellent.
that was the wrong thing to focus on. And what we should be focusing on, what did we do for the stocks of human capital this year? And if you got like 25% of your young people, as in France, or 50% of young people in South Africa who are unemployed when they leave school, you've got a serious problem. And it's not just we have schools that don't teach, but we have kids who are deprived of the chance to learn on the job.
Yeah. Julio, you've been a decision maker. Tell us from your perspective.
I mean, I think the conversation pretty much points to something that also came up in the conversation in the two presentations. We focused a lot on the supply side of these tools, these instruments. We need a parallel effort on the demand side. We need to create the demand in countries and the capacity to carry out. It goes beyond, one important aspect is the quality of the data. I mean, that is certainly something that's there. But it's also the analytical capacity, the accounting capacity, and then the demand from the people who are going to be using the data, the policy makers. And I think that's a complex issue. One of the experiences that we have seen I think both Paul and Kim pointed to this other false dichotomy between producing the evidence and doing the advocacy. But in countries that have done this successfully, you will typically have semi-independent or fully independent think tanks that are somewhere between a buffer, a translator between the work done by academics and the policy makers. And you know, in Mexico, it was the Mexican Health Foundation. And they did that translation. They took the evidence that was mostly produced in universities, took from the global public good, but were able to do the policy translation and then start moving the process towards the advocacy, from the accounting to the advocacy end of that continuum. It is a continuum and a dynamic force. So I think that's a piece of work. And I frankly think the Human Capital Project in particular, because you know, the importance of the 93 report at the World Bank, it was not just the first use of DALIs, it was the first report directed not to health ministers, but to finance ministers. And that was its political impact. It, for the first time, from an institution that talks to finance ministers, was talking about the importance of health. I think that conversation, if we take it to the country level, will have to even force us to rethink the institutional configuration of the way governments are organized. You know, right now you have a clear divide between those parts of government in charge of so-called economic policy and those in charge of social policy, and there's a wall between those, and the dialogue is usually not good, and the political standing of those on the social policy side tends to be weak. Even if health and education and social protection in many countries now account for 2/3 of the budget, it's still, I think we need to rethink how countries, even the institutional architecture of policy making, shifts towards this much more integrated approach where social policy is economic policy, where you can actually develop financial instruments, ratings, credit ratings for governments, including social, and you know, we've done a little bit on environmental variables, but I think bringing the concept of human capital to the center of the economic policy debate is going to be crucial. And that's where the bank, I do think, has a huge comparative advantage because it uniquely can address those. I'm going to discreetly slide out and miss the rest of a fascinating conversation.
Okay, can we just thank Julio as he sneaks out? Thank you, Julio. Just to continue on that theme, and by way of some possible interest, to follow on Julio's point, I should tell you that when I moved from heading the Health Ministry in Australia to heading the Finance Ministry in Australia, the then Treasurer said to me, "Excellent, poacher turned gamekeeper," which makes exactly that point. But Kim, so if you're down on the ground, we all have a kind of great appreciation for evidence, but we also know that, so we talk a lot about decision-made policy that's grounded in evidence, evidence-based policy, something we all cling to as being the gold standard. But of course, in reality, there's sometimes not always evidence-based priorities. And then, of course, if you're a political decision maker or your decision maker literally on the ground, relevance. And then there's the wonderful notion of emotion that gets built in here. So you've been down at that level looking at those things. What do you think from Jim Kim's proposals this morning? I mean, what are the implications for how we decide what we actually do on the ground?
Yeah, I think it was a really inspirational speech. It's one of the best speeches I've heard in a really long time. It got me fired up. As a person trained in social marketing and embedded in social marketing for a long time, I think it comes down to changing behavior and changing someone's behavior. And at this point, you're changing behavior at the decision maker level, whoever that decision maker is, whether it's around a policy, some sort of stick, or it is some sort of financing. And you have to tease it apart. What is, what is your product? Our product here is human capital. What is the price? What does somebody have to give up in order to prioritize human capital over something else? What's the competition? How are you going to promote it so that it's really persuasive to that audience? And who's the best messenger of it? So I look at it as almost a social marketing challenge in terms of positioning it. And I don't know what the answer is, but when people are working on the ground, there are so many other influencers on what they can do.
Absolutely.
That they're doing the best they can with the resources they can get. I think the decisions have to come further upstream for that.
Thank you. And I'll just put you all on notice. I'm going to ask Peter one more question, and then you're going to get an opportunity to ask anybody on the panel a question. So start thinking about what those questions might be now. So Peter, to you, game changer? Yes, no?
GBD, yes, definitely. I think we heard examples yesterday throughout the day from Bill Gates, and then now also I think this human capital initiative proposal, which I find one of the most exciting proposals that I've heard in a long time, because I'm someone who thinks that if there is one good idea per year in the universe, that's a lot. I think this is new, but coming back to the place of evidence, I would like to be a bit more nuanced here. I think in terms of policy and politics and societal choices, evidence is one element and a very important one, but cannot be the only one. It's also, particularly in democracies, I mean, it's what people feel, want, also because we can't do it all. So we need to set priorities among what on base of evidence looks like a priority, and that's true also in health. And we're getting into this kind of discussions now more and more in high-income countries. For example, how far will we go in terms of paying for extremely expensive therapies that extend life by sometimes only a few months, sometimes by years. And where the evidence, a clinician will say, oh, the evidence is very strong, it saves your life. The GBD may say the dollars gained or whatever will be only that, and so on. And then the finance people will say, wait a minute, you know, where are we? And with the aging population, so on. So, but I think it's game changing, and it will continue to be if the emphasis is more and more on the future, on scenarios, and also going beyond the narrow field of health. I mean, when I say in our school that health is a narrow field, they really are pretty upset. But when you go to the, you know, I spoke at the spring meetings and so on, and then, you know, you have to fight to say, hi, I'm from health.
Yeah.
So I think it's, but I'm optimistic. It's also with the foundation is there now. It took a long time, not only just the methodology, but building the community. And managing that community, that may be one of the big challenges, but it's a good challenge to have.
And if you think about it, I mean, one of the things I think we heard from Bill this morning was, you know, the increasing opportunity from the increasing amount of data we've got. The counter to that, of course, is out there. If you're an ordinary person, the world is extraordinarily noisy. Yeah. And I think for those of us who spend a lot of time, for example, dealing with the vaccine issues, we know that people who are talking complete scientific rubbish get a level of traction which we would find collectively distressing. So this is not an easy thing. So I promised you an opportunity to ask some questions, and I'm hoping one or two of you have got some things you would like to ask of the panel. And if I squint into the audience, I can see someone down the back. I think that's a hand. So hopefully someone will appear, yes, with a microphone. And if you could please, I think as we've been asked several times, frame whatever you have to say as a question, not perhaps just a statement. And please tell us who you are. Thank you.
Hello, my name is Reid Sorensen. I've been involved in the forecasting and cost effectiveness work at IHME during the last 3 years or so. And I have a two-part question for you. First of all, what do you think are the most interesting and useful research questions we can ask if we have the ability to say, you know, if we make this change, here's the change in the burden of disease that you might expect? Second part is that much of the discussion around cost effectiveness and forecasting is, you know, how do we allocate resources most efficiently to maximize gains in health? But at the same time, we're all here for equity reasons, that we all recognize that there's a huge disparity between rich countries and poor countries. So I'm wondering, how do you personally think about the trade-offs between efficiency and equity as well? Thank you.
Two big and important questions. Who'd like to go first? Peter? Oh, Paul.
Well, so let me start with going backwards on efficiency and equity. This is part of the mindset of the trade-off, which is the most frequently used kind of framing when we do economic analysis. But the important thing to remember is that applies only when you're on some kind of efficiency frontier. And for most of the world, we're well behind the frontier. So we can achieve both more equity and more efficiency, or like more growth and more equity, because we're not on the frontier. So if you think of catch-up growth, that nations that are farther behind can grow more rapidly, you can actually get both a reduction in worldwide inequality and faster worldwide growth by working diligently to encourage growth in the countries that are farthest behind. And that same mentality could very well apply when we look across people if we do the accounting right and think carefully about what would actually produce more human capital for the society as a whole. So I think there's a real optimism about kind of understanding that kind of catch-up phenomenon in giving us both growth and less inequality.
I'd like to address the first part of the question, if I can. So, you know, the promise of the forecasting tools and the work that IHME is doing. I think it's really promising, and it's a really exciting piece of work, and it gets back to what Peter said earlier. You know, decision makers want to base decisions not on what's happened, but what could be, what are the possibilities. And when I was looking over you know, I haven't read the whole Lancet, but, you know, part of it, you know, what could we do to stop the acceleration of NCDs? I think that would be really interesting just because of the trajectory of the growth in that space. And then getting back to what the panel said also, what other industries or sectors would have to be involved in order to make that kind of change happen, because it's not just a health question. So I'd like to see it used across sectors to really stimulate change.
Yeah, on the first question also I agree with that. And so the art is, on the one hand, I think that today the computing power is such that one can put in variables ad infinitum. And so I think looking at other forecasting exercises, because it's a whole industry, from climate change people to, economics, technology impact and so on, connecting with them and then really go for very sophisticated forecasting, where you always have also some of the unexpected. You mentioned, Jane, the drop in immunization rates, like in this area of Bainbridge Island and so on, the most educated people, they'll want to vaccinate. So these are unexpected things, if you want. But having said that about this, the connect with forecasting, having quite complex, very comprehensive type of models, but then the next step is to simplify that to tools that, the Secretary of the Treasury can use. And I remember when I was in the early days in the 90s in the UNAIDS, we had a super simplistic model about, HIV and what you would do if you, this was before even treatment was available. You introduce condoms or you discriminate, homosexuality and so on. And that's a tool. We did some marketing. We went from one finance minister to the other. The health people, they didn't want to even deal with this because the epidemiologists said, oh, it's not good enough. But that had a major impact. And if we can, if there's such tools, that would be really good. And that can be then adapted to, the level of a country.
I just wanted to come back to this point about cost effectiveness as well, because it relates to what Julio was saying, that the advantage of a standard is it makes possible conversations and conversions that can unify what are otherwise siloed discussions. So that the fact that you've got the traffic fatalities as part of the global burden means that there's conversations that now can embrace the transportation department as well as the health department. And what this broader vision about human capital says is that we just need to bring into this whole conversation the people managing, the labor force and education, and we all got to be using the same, the same measuring rods as we talk about what should we do next. It's really about establishing a common standard for our conversation. My son is a software engineer, and he tells me that the great things about standards is that there's so many to choose from. But, but I think we need to actually just choose one and then start talking.
Yeah, it's interesting, isn't it? And just on the cost effectiveness point, and this I think goes to something that Kim said earlier. We've all seen a situation, haven't we, in respect of a particular therapy, it doesn't cut it in the cost effectiveness stakes. And Australia has been right out at the front on cost effectiveness work for a long time. Herceptin was a classic case of it did not pass the cost effectiveness hurdle, but in the end, the emotion and the context meant it was funded, and of course now the price has come down. So I think always with these things you have to deal with it in a particular context. Now I think we have someone down the front.
Thank you. I'm Ami Banerjee. I'm a cardiologist from University College London. I want to speak to some of Richard Halton's comments earlier about a need for activism, and I'd like to ask the panel what you think the role of the physician and the health professional is in terms of education, activism, and how the interaction with GBD and this kind of data should be. Because the reality is that we have...
Sorry, could you move the mic, point the mic at your mouth a little lower?
No,
okay, because we're having trouble here.
We're having a little trouble understanding. It's that the audio is not great up here. So you're on about activism, that bit I got.
Okay, sorry. So I'll start again. So I was answering Richard Halton's point about activism, and I want to ask the panel about the potential role of the physician in the future... physician and other health professionals in interaction with GBD and data like this, because there are competing movements and we shouldn't exist in our echo chamber, whether it's precision medicine, technology-driven care, and if we don't have the health professionals taken with the tide, then they'll be in competition. And already we've seen that in in medical school curricula, there's been a very slow uptake, disappointingly, of public health, of global health, and not everybody is where they should be with GBD data. So what do you see as the role of the physician, both as a user of the data and an integral producer of the data?
So, like full disclosure, my daughter is a pediatrician. Does cardio intensive care for very young children. So she's my most direct source of information about what it's like to be a pediatrician. The thing I think we all need to pause and think about carefully is this issue about the challenge to science. For me, coming to the bank, it was really the Brexit vote, because the Brexit vote was a vote by about half of the people in Britain who said, oh, if the economists are for it, we're against it. And we need to understand what was behind that. And my instinct is that we weren't careful enough about distinguishing, here's the accounting, here's the numbers, as opposed to, here's what I'm certain is right, and I'll just tell you what's right, and if you disagree with me, you're morally inferior. I think that if that was the kind of signals we were sending, it's no surprise that we were delegitimized. But she wrote reports. She works in California. She reports that it's like the immigrants in the United States, low-income individuals, they all get their kids vaccinated. It's like the software engineers who are part of this anti-vaccine thing. And I just don't have a good explanation for why that community is turning against science. And this isn't probably addressing the breadth of the question you're asking, but I think all of us who've benefited from science and absorbed it have got to think about how we communicate its importance. And in a sense, it's kind of its triviality almost. I mean, science is like accounting, just adding up all the numbers. And sure, there are deep moral and philosophical questions that everybody can participate in, but you got to make sure your numbers add up. And that's part of what we do, and I think we all need to try and send that message.
Okay,
Yeah,
Peter.
I'm the physician on the panel, I think, so I have to say something about it. But I think that what drives most physicians, it's not big data, it's not GBD, it's they want to save, the lives of the patient, or feel the person better. And I think it's fair to say that the overwhelming majority probably think that it's a waste of space in the Lancet and they want to see the results of a randomized controlled trial on the newest therapy for whatever disease they are working on. So let's be real about that. On the other hand, there are physicians for human rights and so on, and it is a profession where, like for any other profession, you find everything from the medical hubris, which is one of the big problems, I think, for healthcare, to the people who are driven by solidarity. And part of it is that in the education, in the medical curriculum, there is basically no space for all this. There is no space for the S word, for solidarity. There's no space for data. There's no space for thinking in terms of populations. And I think we should start there, and also in terms of the selection bias, to use an epidemiological term, of who gets into medical training. That doesn't mean that when I have a problem that I would like to have a physician who is only interested in making me better. But I think that for me, what's driving, and Jim Kim said that very clearly, like in our AIDS experience, it was driven by AIDS activists, people living with HIV, plus a few allies, physicians, but then they were more like the outcast in the medical community.
I mean, I decided I not only got the wrong answer, we should just do science at the bank, but I was asking the wrong question, because the right question is, how do we mix like accounting and advocacy? Partly because when you say accounting, you don't sound like you think you're a demigod as a scientist who can like speak down from Olympus to mere mortals. I mean, accounting is you're just making sure the numbers add up. And there's a division of labor, I think, between these two tasks that we might split our own time between the two. We might split it between, some people concentrate in one instead of the other. But on insisting on the enormous power of just getting the numbers right and seeing what they say, at the same time, we've got to recognize that advocacy is perhaps on a par with science, maybe even more important in terms of shaping our notions of right and wrong.
Yeah.
And that, we didn't end slavery because there was a t-test. We ended slavery because people just said it was wrong, and they were activists who persuaded them. So, accounting, I think, appropriately diminishes the arrogance of the scientific side. Maybe there's another even nobler word than advocacy for the other side, but that might be closer to balance.
Fair enough, Kim.
I was going to say the same thing. Just on a day-to-day basis, I don't think that the physician is in a position to think about GBD. I think a physician is in a position to just make the best decision on behalf of her patient. But what you could do is target the message at a higher level to the AMA here in the US, some sort of association that gives guidance, that does help set policy, that does help prioritize things, and as Peter said, schools in the early training, and maybe there is an opportunity to expose more young physicians to the ideas of broader categories of knowledge like human capital and global health, things like that.
Yeah, and physicians produce a lot of data, but they resent a lot of the increasing bureaucracy in hospitals is really killing the work of a physician. And yet it's these data that also I think we can then tap into for refining the whatever predictions.
But when my kids were born, and you can tell how old I am, but nobody at the hospital worried about whether we had a car seat that we were taking the kid home with, and they worry about that now.
Yeah.
So I think these kind of data about things like fatalities, they do change practice.
Indeed, they did. And I think we always have to remind ourselves, don't we, that in the modern era, you trust the experts who are close to you, who give you personal advice. You tend not to trust experts, and that's a challenge I think that we all have. And the other challenge we have is it's 12:30. And therefore, can I commend you very persistent, stoic types who've sat all the way through a very long morning. Thank you for your attendance. Can I thank the panel for their insightful comments and wish you a good lunch.
Thank you, Madam Chair.
The clock is another one of those.
And if you could return for the commencement of the after lunch session at 2 o'clock, and we'll see you then.